Hello guys, good morning. So today we are going to cover the cranial nerve, which is very important topic for your exam point of view. You can expect a maximum of questions from this particular topic. So there are 12 pair of cranial nerves that are a part of the peripheral nervous system. So you have a Roman numeral which is based on the descending order of the cranial nerve attachment to the central nervous system. So cranial nerve may be sensory, may be motor, or may be both, or you can say maybe mixed. So we have 12 pair of cranial nerves, starting with the first cranial nerve, that is olfactory nerve, optic, third is oculomotor, fourth one is trochlear, fifth is trigeminal, sixth is abducens, seventh is facial, eighth is vestibulocochlear, ninth is glossopharyngeal, 10th is vagus, 11th is accessory, and 12th is hypoglossal. So it is very difficult to remember that cranial nerves in a particular order. So I have two mnemonics. The one mnemonic which I have used during my UG days were this triple O, PTA, triple OTA, UTA, F stands for facial, V stand for vestibular, G stand for glossopharyngeal, V stands for vagus, accessory, and hypoglossal. My mnemonic were Uta Fegva, which I used to use when I was in my UG. Uta Fegva. And if this is difficult for you, so I have one more mnemonic, and that is on old Olympus towering Olympus towering top, a French and German viewed a hope. So the new mnemonic for you is on old Olympus, that is triple O, towering top, that is trochlear and trigeminal, A for abducens, French and German, that is facial and vestibulocochlear, German viewed a hope, glossopharyngeal, vagus, accessory, and hypoglossal. So I have two mnemonic. You opt which one you like. So now it is also very difficult to remember which cranial nerve is sensory, which is motor, which is mixed. So for that I have a mnemonic. Of some say marry money, but my brother say big brain matters more. It means your olfactory sensory, optic sensory, oculomotor, motor. See, oculomotor, it is self-understood, motor. So it is motor. Trochlear motor, trigeminal both, it is mixed. Abducens both, that is mixed. Facial both. Vestibulocochlear sensory, glossopharyngeal both, vagus both, accessory motor, hypoglossal motor. So this is the mnemonic Some say marry money, but my brother say big brain matter more. So this is the ventral aspect of the brain stem, which showing the attachment of the cranial nerve. So your olfactory and optic, these are arise from cerebral hemisphere. While your oculomotor and trochlear, it arises from midbrain. From here, from midbrain. While your trigeminal, your abducen, your facial plus vestibulocochlear, it arises from pons. Next is your glossopharyngeal, vagus, accessory and hypoglossal. It arises from medulla oblongata. Okay, so this particular topic, or you can say line, it is very important from your exam point of view, that the trochlear nerve is the only nerve that arises from the dorsal surface of the midbrain. It is very important for your exam point of view, that the trochlear nerve, it is the only nerve that arises from the dorsal surface of the midbrain. Commonly asked MCQ. So there are certain terminologies, or you can say the functional components, which you have to remember. GSA, that is the general somatic afferent fibers. So these transmit the extroceptive and the proprioceptive impulses from the head and face to the somatic sensory nuclei. While the SSA, that is the special somatic afferent fiber, it transmits the sensory impulses from the special sense organ of vision, equilibrium and hearing to brain. GVA, that is general visceral afferent fibers, these transmit interoceptive impulses from the viscera to the visceral sensory nuclei. Coming on to the SVA, that is special visceral afferent fibers. They transmit sensory impulses from special sense organs of smell and taste to the brain. General somatic efferent fibers, that is GSE, they innervate the skeletal muscles of eye and tongue. SVE, the special visceral efferent fibers, they transmit motor impulses from the brain to the skeletal muscles, which derive from the brachial arches of embryo. These include the muscles of mastication, very important, facial expression and swallowing. Coming on to GVE, which is general visceral efferent fibers. They transmit motor impulse from the general visceral motor nuclei and relate in the parasympathetic ganglions. The postganglionic fiber supplies the cardiac muscles, the smooth muscles and the glands, very important. Now classification of the which all are sensory, which all are motor, which all are mixed, as we have already discussed. Sensory are olfactory, optic, vestibulocochlear. Motor are oculomotor, trochlear, abducen, accessory and hypoglossal. while mixed, which contain both sensory and motor fiber, are trigeminal, facial, glossopharyngeal and vagus. Coming on to the sensory cranial nerve, olfactory cells, they exit from the cribriform foramina, and terminal nuclei is olfactory bulb, and the action of olfactory cells are smell. Ganglion cell, they exit from the optic canal, and terminate nuclei is lateral geniculate body, and action is vision. Vestibular ganglion, that is SSA or cochlear ganglion, it exits from the internal acoustic meatus. These cranial exits are very important, and their terminal nuclei are very important for your exam point of view. So vestibular nuclei and the cochlear nuclei. Vestibular nuclei, the function is equilibrium, and cochlear ganglion, the function is hearing. Coming on to the motor cranial nerves, nucleus of oculomotor, cranial exit is superior orbital fissure. Main action is motor to superior, inferior and medial recti, inferior oblique and levator palpebral superioris. Accessory nucleus of oculomotor is function is parasympathetic to sphincter pupillae and ciliary muscle. Nucleus of trochlear nerve, the cranial exit is superior orbital fissure, and main action is motor to superior oblique. Nucleus of abducent nerve is superior orbital fissure is the cranial exit, while the function is motor to lateral rectus. Nucleus accessory nerve, the cranial exit is jugular foramen. Very important, commonly asked question. And main action is motor to sternocleidomastoid and trapezius. Nucleus of hypoglossal nerve, the cranial exit is hypoglossal canal, and the action is motor to muscle of tongue except palatoglossus. Very important, general somatic efferent nuclei. It includes nucleus of oculomotor, nucleus of trochlear, abducent and hypoglossal. I have a mnemonic, that is HOTA, HOTA. H stands for hypoglossal, O stands for oculomotor, T stands for trochlear and A stands for abducent. Special visceral motor nuclei, motor nucleus of trigeminal nerve, facial nerve, nucleus ambiguous and accessory nucleus. This is the commonly asked question in your AIIMS exam, very important. So special visceral efferent nuclei, motor nucleus of trigeminal site is bone, cranial nerve, fifth cranial nerve, function is masticatory muscle, tensor palati and tensor tympani. Nucleus of facial nerve, nucleus ambiguous and accessory nucleus. Nucleus of facial nerve, site by pons, nucleus ambiguous medulla and accessory nucleus medulla cervical cord, and these are the functions. General visceral motor nuclei, accessory oculomotor nucleus, superior salivatory nucleus, inferior salivatory nucleus and dorsal nucleus of vagus. So I have a mnemonic for this also. The mnemonic is S E I D, seed. S stands for superior salivatory nucleus. E stands for Edinger-Westphal, which is accessory oculomotor nucleus. I stands for inferior salivatory nucleus, while D stands for dorsal nucleus of vagus. These are the site, midbrain, pons, medulla and medulla functions. Please go through it once. Visceral sensory nuclei, general and special. The nucleus of solitary tract, important. Visceral sensory nuclei, nucleus of solitary tract, site is medulla. Cranial nerve involved are 8th, 9th and 10th. Function, taste and visceral sensation. Coming on to the general somatic efferent nuclei. So we have mesencephalic nucleus of trigeminal nerve, this particular. We have main sensory nucleus of trigeminal nerve, this is the main nucleus, this one. And spinal nucleus of trigeminal nerve, this one. So we have general somatic efferent nuclei. So site is midbrain, pons, medulla. All are 5th cranial nerve. Function, proprioception of head, tactile sensation, pain and temperature. Special somatic efferent nuclei. Cochlear nuclei 2, dorsal and ventral. Vestibular nuclei 4, superior, inferior, medial and lateral. Special somatic efferent nuclei, these are very confusing, but you have to remember these because these are the commonly asked questions or MCQs in your exam. So special somatic efferent nuclei, you have nucleus of cochlear nuclei and vestibular nuclei. Site is pons and medulla. Pons and medulla, 8th cranial nerve. Cochlear is sense of hearing, while vestibular is sense of equilibrium. Very important. Coming on to the non-cranial nerve nuclei, nucleus and the site. Gracile nucleus in medulla, cunate nucleus in medulla, superior olivary nucleus in pons, pontine nucleus in pons, nucleus of inferior colliculus in midbrain, grey matter layer of superior colliculus in midbrain, red nucleus in midbrain, substantia nigra in midbrain or pretectoral area in midbrain. Very important. These are the non-cranial nerve nuclei. Yes. Now coming on to the cranial nerve, we have 12 cranial nerve and we are going to discuss them one by one. So starting with the first nerve, that is the olfactory nerve. So starting with the olfactory nerve, that is the first nerve. So origin is the origin of the olfactory nerve is from the mucosa of the upper, upper part of nasal cavity, via cribriform foramina. C. This is the olfactory mucosa of the nasal cavity, and upon this we have the cribriform plate. So the origin is from the cribriform plate to the olfactory bulb, and from the olfactory bulb it transmitted to olfactory tract and divides into two. Next, it is the origin and it ends into olfactory bulb. Olfactory bulb. See, the origin is from the cribriform plate and it goes into olfactory bulb. From olfactory bulb to olfactory tract, it is divided into two portions, that is the medial olfactory and the lateral olfactory. This is the lateral one and this is the medial one. So the medial one the medial one it is opposite to the olfactory bulb. Via anterior commissures. Fine. While lateral one it is lateral to olfactory area of cerebral cortex. So the medial one, the medial one, it is opposite to the olfactory bulb via anterior commissures, while the lateral one, it is lateral to the olfactory area of cerebral cortex. Coming on to the function. The function of olfactory nerve is smell. Fine. Dysfunction, it means loss of function. Loss of function of olfactory nerve leads to anosmia. Which is loss of olfaction. This is loss of olfaction. So this is the olfactory nerve. Its origin, its end, it is divided into two parts: the medial part, the medial olfactory, and the lateral olfactory. The medial olfactory, as I've already told you, and the function is smell. The dysfunction is anosmia. See, these are the olfactory mucosa, or you can say the nasal mucosa. Upon this we have the cribriform plate. So the fiber starts from here, goes into the olfactory bulb. From olfactory bulb it transmitted to olfactory tract and it gets divided into two, which is the medial olfactory and the lateral olfactory. So function, smell. Dysfunction, as I've told you, dysfunction is anosmia. So applied anatomy is head injury may tear nerves filaments passing through the cribriform plate, especially in the fracture involving the anterior cranial fossa. When you have fracture of anterior cranial fossa, so in this we have the leakage of cerebrospinal fluid through nose from tearing of meningeal covering of nerve. Coming on to the second nerve, which is optic nerve. So please keep this in mind that optic nerve is not only a cranial nerve, it is a direct and direct extension of of CNS, central nervous system. This is the only optic nerve This is the only optic nerve which begins in retina. So type of nerve is special sensory. Coming on to the function. Function of optic nerve is, as you all know, vision. Function of the optic nerve is vision. So this is the optic nerve. These are the optic nerve. This is the pituitary gland. This is the optic tract. This is optic chiasm. And the optic nerve, these are begins in the retina. Function is vision and lesion. In this lesion leads to the visual field defects. Visual fields defect. And loss of visual acuity. Coming on to the defect. Defect is anopia. That is the loss of vision. So this is all about the optic nerve, that it has a direct extension. It has a direct extension on the CNS, and optic nerve begins in the retina, and the function is vision and defect is anopia. Coming on to the third nerve, which is oculomotor. It is very important nerve also. So in this, the origin is The origin of oculomotor nerve is from the oculomotor nucleus. From oculomotor nucleus. From oculomotor nucleus, and where it lies? It lies on the medial side of crus cerebri. It lies on the medial surface of crus cerebri along with the lateral wall of lateral wall of cavernous sinus. Okay, so the oculomotor nerve, it is of motor and parasympathetic type. Important, the oculomotor nerve, it is of motor and parasympathetic type. So the origin is from the oculomotor nucleus, and it lies on the medial surface of crus cerebri along with the lateral wall of cavernous sinus. So after entering into the orbit, it gets divides into two parts, which is superior rectus and inferior rectus. This one is inferior rectus. Okay, it get after entering into the orbit through the orbital fissure. It get divides into two, the superior rectus and the inferior rectus. So the parasympathetic fibers pass via inferior division. So the parasympathetic fiber, these are pass via inferior division. Okay, and in this the ciliary ganglion is the peripheral parasympathetic ganglion. Ganglion is the ciliary ganglion. Ciliary ganglion is the peripheral parasympathetic ganglion of oculomotor nerve. Coming on to the components, we have the general somatic efferent fibers, the general visceral efferent fibers. The action of oculomotor, it supplies to superior, inferior, medial recti, inferior obliquus. It supplies to levator palpebrae superioris, sphincter pupilla, and your ciliary muscle. Ganglion is, as I have already told you, the ciliary ganglion. It lies between the optic nerve and the lateral rectus. Coming on to the function, eye movement inward, medially, eye movement inward, upward, downward, outward, pupil constriction, shape and equality, elevates upper eyelid and accommodation reflex. This function, unable to look up, down or medial, tosses, pupil dilatation, and the bilateral and ipsilateral and loss of accommodation reflex. Loss of accommodation reflex. Now coming on to the trochlear nerve, which is the fourth cranial nerve. So the origin is from the trochlea trochlear nucleus, and course is it is the smallest, very important, smallest cranial nerve. It is the smallest cranial nerve, and it is the only nerve to emerge from the this I have told you that it is the only nerve, to emerge. It is the only nerve to emerge from the dorsal part, of brain stem. It is the only nerve to emerge from the dorsal part of the brain stem and its fiber across, and it passes onto the lateral wall of cavernous sinus, then superior to orbital fissure. Okay, so this is the oculomotor nerve. It emerges from the dorsal part of the brain stem. Okay, and it passes on to this is the cavernous sinus onto the wall of cavernous sinus, then to orbital fissure. This is the orbital fissure. So it is the only nerve to emerge from the dorsal part of the brain stem and passes on to the lateral wall of the cavernous sinus and then to the superior orbital fissure. Okay, coming on to the distribution is superior oblique. Dysfunction of trochlear leads to diplopia. That is on looking down and extorsion. Very important point, the trochlear nerve, it innervates the superior oblique muscle, as I have already told you, from superior orbital fissure, and trochlear nerve, it innervates the superior oblique muscle. Coming on to the fifth nerve, which is very important, the trigeminal nerve. So it has three divisions: the ophthalmic division, the maxillary division, and the mandibular division. So this is a mixed nerve. It has three branches: the ophthalmic branch, the maxillary branch, and the mandibular branch. Mandibular, maxillary, and ophthalmic branch. So the motor innervation, innervation. Motor innervation is masseter and temporalis muscle. This is the motor innervation. Coming on to the sensory innervation. Sensory innervation, which is sensory innervation to skin, mucous membrane in head, teeth, tongue, external auditory canal and cornea. So these are the sensory innervations. So trigeminal nerve, it is associated with the derivatives of first branchial arch. So in this, your ophthalmic, this is the ophthalmic division. So it is through the superior orbital fissure, maxillary, it exits from foramen rotundum, and the mandibular, it exits from foramen ovale. So the ophthalmic division, it exits from superior orbital fissure. Maxillary division, it exits from foramen rotundum, while the mandibular, it exits from foramen ovale. Now we are going to discuss this one by one, starting with the ophthalmic nerve. So it gives rise to three terminal branches. That is frontal, lacrimal and nasociliary. So it gives rise to three branches. So it innervates the skin, mucous membrane of derivatives of frontonasal prominence. That is the forehead, and scalp, frontal and ethmoidal sinus, upper eyelid and its conjunctiva, cornea, dorsum of nose. So these are the derivatives. So regarding this, I have, see, the parasympathetic supply is to the lacrimal gland. So this is the postganglionic fiber. The postganglionic fibers from the this is the pterygopalatine ganglion. So the postganglionic fibers from the pterygopalatine ganglion, it travels with the zygomatic branch and then join the lacrimal. This is the lacrimal nerve, and the fiber then supplies to the lacrimal gland. Starting with the starting with your pterygopalatine ganglion, and then it travels with the zygomatic branch and then join the lacrimal nerve, and then it supplies to lacrimal gland. So the supraorbital and the supratrochlear, supraorbital and supratrochlear, these are the terminal branches of the frontal stem of ophthalmic branch. So these are the terminal branches of frontal stem of ophthalmic branch. So very important, your ophthalmic nerve, it enters through superior orbital fissure. So your ophthalmic nerve, it enters through superior orbital fissure. Important. So ophthalmic is having the three branches. The frontal, the nasociliary and the lacrimal. Three branches are frontal, nasociliary and lacrimal. 1, 2, 3. Now coming on to the second division, which is the maxillary nerve. So the maxillary nerve, it gives rise to 14 terminal branches. It gives rise to 14 terminal branches, which innervates the skin, mucous membrane and sinuses of derivatives of maxillary prominences. Maxillary prominences, which is the derivative of first branchial arch. So derivatives are lower eyelid, and its conjunctiva, lower eyelid and its conjunctiva, the cheeks maxillary sinus, nasal cavity and lateral nose, upper lip, upper molar, incisor and canine and their associated gingiva. Last is superior palate. So these are the derivatives. So the parasympathetic, it supplies to the lacrimal gland. This is the lacrimal gland and the nasal branches, or you can say the nasal gland. So the parasympathetic, it supplies to lacrimal gland and nasal gland. Very important that maxillary division, in this I have told you the nerve passes from foramen rotundum. Nerve passes through foramen rotundum. Now coming on to the mandibular nerve. After discussing the ophthalmic and the maxillary nerve, now we are discussing the mandibular nerve. The mandibular nerve. So it is the largest of all the three nerves. It is the largest, and it arises from the cranium. It arises from the cranium of the lower border of the trigeminal ganglion. It arises from the lower border. It arises from the cranium, from the lower part of the trigeminal ganglion, and enters into temporal fossa. And after this, it is divided into anterior branch and posterior branch. It is divided into anterior branch and the posterior branch. So the anterior division, it is composed of the chiefly motor fibers, and it is divided once into the deep temporal nerve and nerves to the masseter, the anterior one, and the lateral pterygoid buccal nerve. This is the anterior division to lateral pterygoid. It divides almost at once in the deep temporal nerve and the nerve to masseter and lateral pterygoid and the buccal nerve. In this, the sensory fibers pass into the buccal nerve. It is very important for your exam point of view. Coming on to the posterior division, the posterior division gives off the two roots, one in the auriculotemporal and other in the lingual or the inferior. alveolar. So the only motor fiber in it are those that form the mylohyoid branch. This is the anterior, which gives off the buccal nerve. The posterior one is auriculotemporal, another is the mylohyoid, or then it divides to the lingual and inferior alveolar. So inferior alveolar, it enters inferior alveolar nerve, it enters the mandibular foramen. Okay, and the parasympathetic supply, the parasympathetic supply is to all the three salivary glands, that is the submandibular gland and the sublingual, submandibular, sublingual and parotid. So the parasympathetic supply is to the submandibular, the sublingual and the parotid gland. So these are the branches of the mandibular nerve which innervates the skin. The mucous membrane, the striated muscle derivation of the mandibular nerve, the prominence of the first pharyngeal arch, as I have already told you. So the sensory supply is to the mucous membrane and the floor of oral cavity, external ear, lower lip and chin, interior 2/3 of the tongue, lower molar, incisor, canine teeth associated with gingiva, motor supply to the muscles of mastication, medial pterygoid, lateral pterygoid, masseter and temporalis, all the muscles of mastication, anterior belly of digastric, tensor villi palatini and tensor tympani. So the dysfunction of the trigeminal nerve leads to trigeminal neuralgia. The other name of trigeminal neuralgia is tics dolorix. Tic dolorix. So these are the ophthalmic division. This is your maxillary and this is your mandibular. In ophthalmic you have supraorbital, supratrochlear, infratrochlear and external nasal and lacrimal, while in your maxillary you have zygomaticotemporal, infraorbital and zygomaticofacial, and in your mandibular division you have auriculotemporal, buccal, mental. And now next nerve or the sixth nerve is the abducens nerve. So the origin of the abducens nerve is through the abducens nucleus. This is the abducens nucleus. So origin is from abducens nucleus, and the course it has very important, it has a longest subarachnoid course. It has longest, very important for your exam point of view, longest subarachnoid course of all the cranial nerve. It emerges between pons and medulla, and then passes through cavernous sinus and enter into the orbit. Through superior orbital fissure. So the origin of abducens nerve is through abducens nucleus. So it emerges. It is the longest subarachnoid course. So it emerges between the medulla and the pons. And passes through the cavernous sinus. And enters to the orbit. This is the orbit through superior orbital fissure. Enters to the orbit through superior orbital fissure. So its distribution, it supplies to lateral erectus. This function leads to medial deviation and diplopia. So it enters through abducens nucleus. Origin is abducens nucleus, and it passes through the pons and medulla oblongata, emerges between the pons and medulla oblongata, passes through the cavernous sinus, entering into the orbit through superior orbital fissure. Coming on to the seventh cranial nerve, which is the facial nerve. So the origin of the facial nerve is from pons and medulla. Origin is from pons and medulla, and course so it leaves the skull through the internal acoustic meatus. It leaves the skull through internal acoustic meatus, facial canal, and stylomastoid foramen. Stylomastoid foramen, and then it enters to parotid gland. From where it divides into 5 branches. It gets divided into 5 branches. So the branches within the facial canal are: number 1, cauda tympani, greater petrosal nerve, stapedial, pterygopalatine ganglion, and submandibular ganglion. So these are the branches within the facial canal. Coming on to the branches which are outside the facial canal. Temporal, zygomatic, buccal, marginal mandibular, and cervical. I have already told you the mnemonic of these 5. तुम ज़्यादा बातें मत करो. तुम ज़्यादा बातें मत करो. These are the mnemonics of this. So your facial nerve, it gets divided into 5 branches. Branches within the facial canal, branches outside the facial canal. Coming on to the function of this: control of facial muscles, motor limb of blink and corneal reflex, secretion of salivary and lacrimal glands, sensation of taste in anterior 2/3 of the tongue. This function, number 1, is motor, leads to facial asymmetry. In this is ipsilateral weakness or paralysis of right or left, indicative damage to motor nucleus and peripheral component. Example, Bell's palsy. Coming on to the contralateral weakness, that is paralysis of lower face, indicative of contralateral motor cortex damage. Bilateral weakness or paralysis, example, myasthenia gravis and Guillain-Barré. Coming on to the parasympathetic, loss or excessive tearing or salivation. Sensory, loss of taste from anterior 2/3. Combined is speech difficulty and drooling or difficulty in handling the food. Coming on to the 8th nerve, that is the vestibulocochlear nerve. So it comprises of the 2 parts: the vestibular nerve, or you can say the vestibular fibers, and cochlear fibers. So the component of this is arise from the vestibular component, it arises It arises from the vestibular nucleus, from the vestibular nucleus, complex in pons and medulla. While the cochlear component, it arises from the ventral and dorsal cochlear, ventral and dorsal cochlear nuclei, which is situated in the inferior cerebellar peduncle, So these both combine in pons to form the vestibulocochlear nerve. So can you see this? This is the vestibular nerve, this is the cochlear nerve. So these both combine to form the vestibulocochlear nerve. Okay. One more thing. The vestibulocochlear is passing through internal acoustic meatus. Important. So coming on to the function, the vestibular part, it conveys the impulses associated with the balance of the body, while the cochlear part, it conveys the impulses associated with the hearing. So with the distal aspect of the internal acoustic meatus, the vestibulocochlear, this vestibulocochlear, it gets splits into two. One is the vestibular nerve and another is the cochlear nerve. The vestibular nerve, it innervates the vestibular system of the inner ear. This one, the vestibule, it innervates the vestibular system of the inner ear, which is responsible for detecting the balance. While the cochlear, this nerve, it travels to the cochlea of the inner ear, forming the spiral ganglia, which is the sense of hearing. So this vestibular nerve, it passes through the inner ear, while the cochlear nerve, it travels to the cochlea and form the spiral ganglia. So vestibular neuritis, these are the dysfunction of the vestibulocochlear nerve. So the vestibular neuritis, it refers to the inflammation of the vestibular branch of the vestibulocochlear nerve. So the symptoms of this vestibular neuritis is vertigo, nystagmus, loss of equilibrium, and nausea and vomiting. Coming on to the labyrinthitis. So it refers to the inflammation of the membranous labyrinth resulting in the damage to the vestibular and cochlear branch of the vestibulocochlear nerve. The symptoms are the sensory neural hearing loss and tinnitus, which is a false ringing or the buzzing sound. Next is the acoustic neuroma symptom, which is the vestibular schwannoma. The first symptom is usually gradual loss of hearing in one ear, often accompanied by tinnitus, which is the false ringing and buzzing sound. Coming on to the ninth nerve, which is the glossopharyngeal nerve. It is very important nerve, though number of questions came from this particular nerve. So the glossopharyngeal nerve, it originates from the medulla oblongata of the brain. So this nerve, this has 4 nuclei. The 4 nuclei, in which 2 are sensory, and 2 are sensory and 2 are motor. So in this the nerve leaves the cranium via jugular foramen. So the nerve leaves the cranium via the jugular foramen, and immediately outside the jugular foramen there are 2 ganglia. Outside the jugular foramen there are 2 ganglia, the superior ganglia and the inferior ganglia. This is the superior ganglia and this is the inferior ganglia. Outside the jugular foramen there are 2 ganglia, which is the superior, this one is the superior and this is the inferior. So the function of the superior ganglion and the inferior ganglion is they contain the cell body of the sensory fiber. So function is they contain the cell bodies of sensory fibers in glossopharyngeal nerve. So this is the function of your superior as well as inferior ganglia. So they innervates motor, which is stylopharyngeus muscle and sensory to carotid sinus. So it innervates the motor stylopharyngeus muscle and to sensory the carotid sinus. So the parasympathetic, it provides the parasympathetic innervation to parotid gland, very important. Sensory, special sensory, they provide the taste sensation to the posterior 1/3 of the tongue, while the sensory, they innervates the oropharynx, carotid body and sinus, posterior 1/3 of the tongue, middle ear cavity and eustachian tube. So the motor nerve, it innervates to the stylopharyngeus, and the sensory, it innervates to carotid sinus. So the glossopharyngeal nerve, it terminates by splitting into the two sensory branches, into the three sensory branches. Number one is the pharyngeal branch, second is the lingual branch, and third is the tonsillar branch. So the glossopharyngeal nerve, it terminates by splitting into the three branches: tonsillar, pharyngeal, and lingual. So the pharyngeal branch, it combines with the fiber of vagus and vagus nerve to form the pharyngeal plexus and innervates the mucosa of the oropharynx, while the lingual branch, it provides posterior 1/3 of the tongue with the general and the taste sensation, while the tonsillar branch forms a network of nerves known as tonsillar plexus, which innervates the palatine tonsil, important, and the glossopharyngeal nerve provides the parasympathetic innervation to the parotid gland, as I have already told you, and the dysfunction of glossopharyngeal nerve leads to dysphagia. Coming on to the 10th nerve, which is the vagus nerve. So the vagus nerve, it is associated with the derivative of fourth pharyngeal arch. Very important, this particular muscle has the longest course of all cranial nerve. So it originates in the head. So in the head, it originates from the medulla of the brain stem. Originates from the medulla of brain stem, and it exits the cranium. It exits the cranium via jugular foramen and with the glossopharyngeal and accessory nerve. With glossopharyngeal and accessory nerve. So in the head, it originates from the medulla of brainstem and exits the cranium via jugular foramen with the glossopharyngeal and accessory nerve. So within the cranium, the auricular branch arises. Within the cranium, the auricular branch arises which supplies sensation to posterior part of external auditory and external ear. So in this we have majority of branches arise. So from this we have majority of branches which is arise from the neck. So these are the pharyngeal branches, the superior laryngeal nerve and the recurrent laryngeal nerve. This is the superior laryngeal nerve and this is the recurrent laryngeal nerve. Okay, so the superior laryngeal nerve, it splits into the internal and the external branches. The external laryngeal nerve innervates to the cricothyroid muscle of larynx, and the internal laryngeal nerve, it provides sensory innervation to the laryngopharynx and the superior part of the larynx. While the recurrent laryngeal nerve, it hooks, this is the laryngeal nerve, it hooks underneath the right subclavian artery, then ascending towards the larynx, and it innervates the majority of intrinsic muscles of larynx. Coming on to the sensory function. Somatic refers to the sensation from the skin and the muscles, and visceral sensation innervates the laryngopharynx, the superior aspect of larynx, the heart and the gastrointestinal tract. So in the thorax, the right vagus nerve, this is the right vagus nerve, forms the posterior vagal trunk. The branches from the vagal trunk contribute to the formation of the esophageal plexus. While the left recurrent laryngeal nerve, it hooked under the arch of the aorta and ascending to innervate the majority of intrinsic muscles of the larynx. And the cardiac branches, these innervate, regulates the heart rate and provide the visceral sensation to the organ. Coming on to the motor function, the vagus nerve innervates the majority of muscle associated with the pharynx and the larynx. Most of the muscles of the pharynx are innervated by the pharyngeal branches of the vagus nerve, which are superior, middle, inferior pharyngeal constrictor, palatopharyngeus, salpingopharyngeus, and muscles of larynx. Parasympathetic functions: in the thorax, abdomen, the vagus nerve; in the heart, the cardiac branches, while in the GIT, it is the vagus nerve. Before coming on to the next nerve, the dysfunction of the vagus nerve leads to paralysis of superior laryngeal nerve, superior laryngeal nerve, superior laryngeal nerve, paralysis of recurrent laryngeal nerve, paralysis of recurrent laryngeal nerve, loss of gag reflex, and GIT, dysfunction. So these are the dysfunction of the vagus nerve. Now coming on to the next 11th cranial nerve, which is the accessory nerve. So it is the 11th paired cranial nerve. So origin is from medulla. It divided into two parts: cranial part, which is developed from the nucleus, very important, ambiguous. It is developed from the nucleus of ambiguous. So in this, see, it is developed from medulla. We have two parts, the cranial part and the spinal part. Okay, see, this is the cranial part and this is the spinal part. So the cranial part, it unites with the vagus nerve and supplies the voluntary muscles of larynx, pharynx and esophagus, while the spinal nerve, it supplies to sternocleidomastoid and trapezius. Okay, it has two parts, the cranial part and the spinal part. The spinal part, it supplies to the trapezius muscle and the sternocleidomastoid muscle, while the cranial part, it supplies to the larynx, pharynx and esophagus. Coming on to the last nerve, which is the hypoglossal nerve. So the origin of the hypoglossal nerve is it arises from the hypoglossal nucleus. It develops from the hypoglossal nucleus, from the medulla oblongata. And the hypoglossal nerve, it runs inferior to the tongue. And innervates to the tongue muscles. So it is developed from your medulla oblongata and it innervates to the tongue muscle. These muscles. So function of this is motor to all the muscle except the tongue. So the function is motor to all the muscle of the tongue except the palatoglossus muscle. So what all are the muscles of tongue? The extrinsic muscles are your genioglossus, your hyoglossus, your styloglossus. These are the extrinsic muscles. The intrinsic muscle are the superior longitudinal, the inferior longitudinal, the transverse and vertical. So it is applied to all the muscle of the tongue except the palatoglossus. It allows the movement of the tongue during the speech and the swallowing. So lesions, dysfunction is difficulty in chewing and speech. The tongue paralysis, atrophies, become shrunken and furrowed on the affected area, and on the protrusion it deviated to the affected side. These are the dysfunction. So these are the dysfunction. So reflex related to the cranial nerve, these are very important one-liners. Pupillary, it is related to cranial nerve number 2 and 3. Accommodation, cranial nerve number 2 and 3. Corneal or blinking, it is related to 5 and 7. Lacrimation, cranial nerve 5 and 7. Salivation, cranial nerve 1, 2, 5, 7 and 9. Sneezing, cranial nerve number 1, 5, 9, 10 and actually I have write it down in not in the Roman number, I have write it down in the complete 1, 2, 3, 4. But vomiting related to 1, 5, 7 and 9. Yawning related to 5 and 7. Swallowing related to cranial nerve number 5, 7, 9, 10, 11 and 12. Jaw jerks, cranial nerve number 5. Stapedial, cranial nerve number 8 and 7. Cough, cranial nerve number 9, 10, 11. Gag, number 9 and 10. Carotid sinus, number 9 and 10. And I have some important point. Please note it down that the longest intracranial course is trochlear nerve. The largest cranial nerve is trigeminal. The most extensive distribution is of vagus nerve. Most commonly paralyzed nerve is facial nerve. Longest intraosseous course is of facial nerve. Commonly involved intracranial aneurysm is oculomotor and abducen. So these are some of the important points. See, I have some important one-liner also. These are very important for your exam point of view. Please go through these point once. The cranial nerve with the longest intercranial course, longest course, abducen nerve. Please go through it once. It is very important. These are the important one-liner. These are also some important points, some important one-liner which are important for your MCQs point of view and your exam point of view. So this is all about the cranial nerve. This is very important topic. Please go through it once. Thank you.